Hello, guys, and welcome to Global Perfusion Community. So today, once again, we have Miss Zahara with us, and she's going to share her wonderful topic that is Cardioplegia delivery techniques and strategies. So I welcome you all in this live session, and we'll have a wonderful session because this is a very wonderful and important topic. And I welcome Miss Zahara.
Thank you. Hello, everyone.
Yeah.
I hope everything is going well. My name is Zahra Gambari. I'm a master student in cardiovascular perfusion from Iran. And today I want to talk about the cardioplegia, cardioplegia technique and strategy. So go to first slide, please.
Yes.
Thank you. The aim of cardioplegia delivery are uniform distribution of the solution, achieve complete diastolic arrest, and maintain metabolic protection and prevent ischemia, and minimize myocardial edema and metabolic washout. Strategy depends on patient anatomy, pathology, type of cardioplegia, and surgical procedures. So go to next slide. Thank you. This slide discusses about the cannulation strategy. One method is antegrade. Actually, we injected cardioplegia uh, via arterial to the coronary arteries, and distal region may not be adequately protected in coronary disease. The pressure of this method is 60 to 100 mmHg, millimeter of mercury actually, and the flow is 200 to 300 milliliter per minute. Monitor pressure is so important for prevent uh, complications such as rupture. And we should to avoid air embolism. So actually, meticulous airing is so important. Other method is retrograde. Actually, we injected cardioplegia via coronary sinus and following backward to the venous system into the coronary arteries. So the normal pressure in this method is 20 or 30 to 40 mmHg, and the flow is 50 to 150 milliliter per minute. And actually useful for some patient who had coronary artery disease, aortic insufficiency, and reduced surgery. The advantage of this method, retrograde I mean, is a uniform perfusion of subendocardial region in patients who have coronary disease. And the disadvantage of this method is poor distribution in right heart region. And retrograde need balloon tip cannula to prevent leakage. Other method is combine, actually combine antegrade and retrograde. And now I want to talk about the sequential and simultaneous. What is the difference between both of them? Sequential, in sequential, we give antegrade first and then retrograde, and we can add intermittent doses if needed. And in a sequential, actually, we focus on stepwise reinforcement of poorly perfused area. And about simultaneous, actually give antegrade and retrograde at the same time with lower pressure. Uh, and we focus on uniform myocardial protection. So go to next slide, please. Thank you. Selective ostial cannulation. Actually, used this method used in AVR or aortic valve replacement or root replacement surgery. The normal range of pressure in this method is 50 to 70 mmHg and require careful de-airing and the monitoring. Uh, so go to next slide, please. Thank you. Graft perfusion. Native coronaries may be blocked, and we actually newly constructed graft bypass the ischemic territories. One type of graft is LIMA, Limi, or left internal memory artery. Uh, if I want to talk about the characteristic of this graft, actually is arterial graft with muscular wall and prone to vasospasm. So we should to use vasodilators such as papaverine to prevent this spasm. And this graft located along the chest wall. The other graft is RIMA, or right internal mammary artery, and it's very similar to lima. The pressure for both of them, rima and lima, is we should to maintain pressure for this graft less than 60 mmHg to avoid damaging and actually triggering spasm. So other graft is radial artery. Radial artery in upper limb, forearm actually. The characteristic of this graft is muscular arterial wall and spasm prone, actually more than lima. Uh, so we should to use vasodilators such as nitroglycerin and papaverine, and we should to keep temperature more than 10 degrees centigrade, because lower than this range can actually can higher the risk of spasm. So, and the pressure like lima and rima, we should to maintain pressure less than 60 mmHg. Other graft is SVG, or Stephanus vein graft from the leg. And the characteristic of this graft is thin walled vein, more delicate than artery. So we should to maintain pressure less than 40 mmHg, and we should to use gentle cannula tip to avoid injury. And if I want to talk about the delivery strategies via graft, one of them is distal graft cannulation. Cardioplegia injected directly into the distal anastomosis. Other is hybrid strategy, actually combination of native road plus grafting injection plus retrograde. And we use hybrid strategy to hypertrophied heart, reduce surgery, and multivessel CABG. And other strategies such as sequential and simultaneous perfusion. In sequential, each graft perfused separately, and simultaneous multi-graft perfused together. And there is some technical consideration. One of them is manifold system. Manifold system is actually allows quick switching between native route and graft during cardioplegia delivery. So, other is pressure monitoring. Each graft line needs separate pressure control, and very important actually. Distal ball duct clamp prevent backflow of blood during graft perfusion, and we can use vasodilator, I say it, such as nitroglycerin and papaverine. And temperature control is so important. Graft can be cold or warm. So there is some problem that may be occur during graft perfusion. One of them is non-uniform myocardial perfusion. The solution is combined antegrade, graft, and retrograde delivery method. Actually, combine both of them. And other problem is graft rupture. The solution is reduce the perfusion pressure, use soft or blunt cannula tip to minimize trauma, and we can check distal clamp to make sure the graft isn't closed off. Other problems such as vasospasm is related to radial artery and lima, not SVG. So the solution is administer vasodilator, warm solution, infuse cardioplegia slowly. And other problem is like air embolism. The cause of this problem is improper de-airing. So I say meticulous de-airing is so important. And the solution is carefully flush all line and use bubble trap is so important. So I think enough for this slide. Go to next slide, please. Thank you. Flow and pressure control. This slide discuss about that the pressure control is more important than the flow control actually, because even if flow is low, higher pressure can damage the graft. So control pressure is so important. There is some modern pumps that they have dual mode for flow and pressure with alarm. Um, and about the pressure range, I say for antegrade, the normal pressure range is 60 to 100 mmHg. Retrograde is 20 or 30 to 40 mmHg. And for graph, radial and lima and rima is less than 60 mmHg. And for Cephalus is less than 40 mmHg. So avoid high pressure to prevent edema, and endothelial damage is so important. Go to next slide, please. Thank you. Timing and interval. Timing and interval actually depend on which type of cardioplegia do you use. For example, for cold blood, we injected in 4 to 10 degrees centigrade and intermittent, and we re-injected after 50 to 20 minutes. Warm blood injected in 30 to 37 degrees centigrade continuous, and for crystalloid, usually we injected them cold, intermittent, and we actually injected maintenance dose of them after 20 to 30 minutes. So actually all of them, it's related to which type of cardioplegia do you use. And we should to prevent ischemia drift. What is ischemia drift? Ischemia drift actually due to gradient, pressure gradient. So control the pressure is so important to avoid this complication. Um, Go to next slide, please. Thank you. Distribution and temperature management. Antegrade is better perfusion of subendocardium, and retrograde less subendocardium, that subendocardium coverage. Monitor LV, RV, and septum for temperature is so important, and we should to keep difference between perfused and myocardium less than 10 degrees centigrade. Actually, flow adjustment at low temperature and cold solution can increase the viscosity, and by increase the viscosity lead to decrease the penetration of cardioplegia. So control the temperature is so important. Go to next slide, please. Thank you. Venting and LV decompression. Retrograde cardioplegia with aortic insufficiency (AI) lead to LV distension. Blood can flow backward into the left ventricle (LV) and stretching the ventricle. Distension reduce cardioplegia delivery actually to subendocardium, and increase the risk of ischemia. So the solution for this problem is insert a band catheter to drain excess blood and actually reduce retrograde flow, and we can change to antegrade perfusion. So go to next slide, please. Thank you. Continuous vs versus intermittent delivery. Continuous delivery in this type, cardioplegia flows constantly without interruption, and the advantage of this type is uniform myocardial protection, especially endocardium actually, and fewer interruption lead to lower ischemia risk. Used in lung surgeries, multi-graft procedures, and hypertrophied heart. And about intermittent delivery, cardioplegia given in periodic doses, not continuously actually. And the advantage of this type is a less hemodilution, simpler system to control pressure and temperature. And the disadvantage of this type, intermittent I mean, is a brief interruption may reduce protection to some area. And there is some strategies, hybrid strategies, actually combine both continuous and intermittent. Uses stranges of both methods and often best choice for complex or multi-graft surgeries. So go to next slide, please. Thank you. Reperfusion and hot shot. The route of hot shot usually is antegrade and or maybe via graft. The reason of this is this route deliver warm and oxygenated blood efficiently to all myocardial layer before restoring normal circulation, and we don't use retrograde because it may cause LV distension and does not reliably perfuse the subendocardium. And I say the temperature of the hot shot is 37 degrees centigrade, and we injected in 2 to 3 minutes. And the goal of hot shot is wash out acidic metabolites, restore ATP, reduce perfusion injury. So I think enough for this slide. Go to next slide, please. Thank you. Advanced and modern concepts. Number one is smart pumps. Smart pumps automatically adjust pressure and flow. And micro catheter allows selective perfusion of specific graft or myocardial region. Optical and thermal sensor monitor oxygenation and temperature in real time. Dynamic temperature gradient. We should to change the temperature slowly. A gradual temperature change reduce vasospasm and cell injury. And the last one is micropelagia, a long-acting solution such Delnido and HTK hybrid. They prolong myocardial protection. So go to next slide, please. Thank you. Special situation. Number one is aortic insufficiency. Retrograde perfusion is preferred to avoid LV distension. For hypertrophy, we can combine antegrade and retrograde road to ensure subendocardial perfusion. Actually, redo surgery we can use graft and plus retrograde. For congenital and single coronary arteries, we can selective perfusion targets abnormal or single coronary artery. And for heart transplant, for donor heart, antegrade method is better, delivery is better, and for recipient heart, retrograde is better. So go to next slide, please. Go to next slide, please. Excuse me, do you hear my voice? If you hear my voice, please go to the last slide. Mr. Vivek, can you hear my voice?
Okay, hello guys, welcome back. So I'm extremely sorry. There was a technical error, so that's why we couldn't come live again. But now we are back, and we'll continue the session now. Okay,
I last slide, yes?
yeah, just a minute. Actually,
Okay,
there was a technical issue.
never mind, sir. It's normal.
Okay,
Yes.
so we were on the last slide, I guess.
Yes.
Okay, so you can continue.
Okay.
Yeah.
This is the last slide and talk about the troubleshooting problems that may be occur and how to solve them. Number one is non-uniform arrest. So we combine antegrade, retrograde, and graft to solve this problem. For LV distension, I say we should to use a vent and reduce the flow. And high sinus pressure, we check the cannula, and if there is malposition, we reposition cannula and reduce the flow. And for graft vasospasm, I say we should to use some drugs such vasodilators such as nitroglycerin and papaverine. And for air embolism, meticulous bearing is so important, and flush all the line and cannula and use bubble trap is useful for avoid these problems or troubles. Thank you for hearing me. If you have any question, leave your question in your comment and I answer
Okay,
your question.
okay. So thank you, Zahra, for a wonderful session. Now we
Thank
are
you.
going to have our Q&A session. We have few questions over here. So, guys, I request you to comment your questions in the live chat. We'll pick your questions and we'll try to answer the question. So, we have a question over here. So
Yes.
it's from Priyavati, Priyavati from
What
India.
are yes?
Yeah.
What are a strategy for myocardial protection? Actually, there are many strategies, and all of them depend on the patient type of surgery and the many factors. For example, you can use warm blood. Actually, it's related in the patient condition. For example, for patient who has a low ejection fraction, it's better to use blood cardioplegia and actually shorter interval. And for the normal patient, we should to use cold cardioplegia to reduce the metabolism of the cell and avoid the reperfusion injury. Uh, if you ask your question in detail, I think it's better.
Okay. So, Priyavati, you can ask again. You can ask your question in detail if you want any detailed explanation. Okay. So, we'll go to the next question. So, it's again from Priyavati.
Yes,
What is
what is
warm blood cardioplegia?
warm blood cardio is type of cardioplegia that we use in some patients who have, for example, low ejection fraction, or other patient that we consider that the blood is better for them because blood cardioplegia contain oxygen and glucose, and it's very good for the heart. And I don't know. Say what about warm blood cardioplegia?
So actually, warm blood cardioplegia is a cardioplegia which
Yes,
we give. Mostly, it is used for a short procedure,
yes,
and the most important benefit of warm blood cardioplegia is that it doesn't have any reperfusion injury
yes,
because when we use a cold cardioplegia, we reduce the temperature of the myocardium, right? So the metabolic activity of the myocardium is reduced when we give the cold cardioplegia. But
yes.
in this warm blood cardioplegia, we maintain the myocardial temperature, that is around 34 to 37. So the myocardium has its metabolic activity. The metabolic activity is maintained. So when we release the clamp, when the coronaries are perfused again, so the chance of reperfusion injury is reduced because the metabolic activity is maintained during the cross clamp.
Yes.
So
And
do you
actually,
yeah.
one of the aim of hot shot is to increase the metabolism of the cell after
No,
cooling the
no, no,
heart.
actually, hot shot is different. I'm telling about the warm blood cardioplegia.
Okay, okay, yes.
Okay,
No, no,
sometimes yeah, yeah, you
yes,
can tell
okay.
me. So sometimes we give a warm blood cardioplegia. It has the same composition as the cold cardioplegia, and it is used to arrest the heart. But the difference is only the temperature is maintained around 34 to 37 in warm blood cardioplegia,
Yes.
and in cold cardioplegia we maintain the temperature around 8 to 12
4
degrees.
to 10 degrees.
Yeah, and the other thing is hot shot is a different thing. Hot shot is given before releasing the cross clamp.
No,
So this
I
is
want to say
given.
that
Yeah,
warm blood don't need hot shot. Hot shot is for cold solution because one of the aim of hot shot is to increase the metabolism of the cell.
yeah,
So
yes,
when we
yes.
warm blood, actually the enzyme of the cell are active, so they don't need to use a hot shot for warm blood actually.
Yeah. Okay, so we'll go to the next question. Um, okay, so we have one more question. What cardioplegia technique after Del Nido cardioplegia?
Uh, After the nido, which cardioplegia technique? You can actually the route of delivery. The answer is the route of delivery.
Yeah, maybe the
Maybe
actually the question is not clear.
yes, maybe
Yeah,
antegrade retrograde is about it's related to the anatomy of physiology of the heart. For example, if the coronary arteries are obstructed, so we should to use retrograde and other method.
okay. So we'll go to the next question. We have one more question. Uh, does hot shot uh, can have myocardial injury because of temperature 37? So okay,
No, actually, the aim of hot shot to avoid injury, reperfusion injury, actually. So, but the control of the temperature gradient is so important. For example, you should to rewarming gradually, not very fast.
yeah,
Uh, so, control the range of temperature is so important. But no, hot shot is very good to avoid injury.
okay. Okay, we have one more question, and it is the same question. What is
Yes.
warm blood cardioplegia? So, as we discussed earlier,
You know, we can inject blood cardioplegia cold or warm, but choose each one of them is related to the patient condition, type of surgery. For example, for lung surgery, we should to inject
yeah,
cold blood, no warm blood. So you should to consider all of the factor and choose the warm blood or cold blood. And I think it's, if
yeah.
you have
Actually, for a complicated case, we should prefer cold cardioplegia. And
yes.
if there is a simple, straightforward case which doesn't require a long time arrest, we can go with the warm blood cardioplegia. We can maintain the temperature up to 34 of the myocardium. But if there is a complicated case and if the arrest time is for a long period, so we should definitely prefer cold cardioplegia because it reduces the myocardial metabolic rate and it reduces the oxygen demand of the myocardium. So cold cardioplegia is a best option for um, a long period of arrest, and warm blood cardioplegia can be used for a short time. So we have one more question.
Yes.
So it is from Priyeseto from Indonesia. Uh,
No, I say you, the hotshot cannot be delivered via retrograde route, just via antegrade and via graft. Because if you deliver hotshot via graft, maybe lead to LV distension and less perfuse subendocardial. So just you can deliver in antegrade route and via graft.
okay. Okay. I think this question is a bit uh, confusing. I think the question is, can hotshot be delivered via retrograde route? So I think sometimes we can give it through retrograde if the antigrade is not, but most of them never use this route for hotshot.
Do you hear my answer of this question?
Pardon?
Do you hear my answer of this question?
Yeah, yeah, I got it.
Okay. I said we can't we can deliver via retrograde, just antegrade, and actually via graft. And the reason of that is because maybe lead to LV distension and less perfusion of subendocardial.
Okay, so we have one more question. We'll go to the next question,
Okay.
and the
My
question
question.
is, during transplantation
Yes, time.
time, donor heart um cardioplegia given, which I think which
Which kind of
cardioplegia
delivery?
given? Yeah.
For donor heart, I say antegrade is better, and for recipient heart, actually retrograde delivery is better.
Okay. Okay. So this is a very important question. How
Yes.
can we assess that graft vasospasm has occurred during the administration of cardioplegia?
Okay. For example, you say the flow is less, but the pressure is high, higher pressure and the low
Yeah.
flow. So you should to check the cannula. Maybe there is malposition, and see the waveform of the EKG if they are flattened or low amplitude. Uh, you should to check the cannula to reposition it and actually adjust the flow and pressure.
Yeah. Okay. So while giving cardioplegia through the graft, we should make sure that the pressure is adequate. We should not exceed the pressure limit. We should check for the resistance, and also we should check the ECG. If there is any activity in the heart, that means um, the cardioplegia which we have delivered through the graft is not sufficient, or it has not been delivered properly. So we should check the pressure and also the ECG. Okay, we have one more question. It's from Mali Inok from
Yes,
India.
for congenital, I say we should to use selective cannulation for this patient is better.
Okay. Okay. Can you explain in detail about this?
Yes, for example, we injected directly via each vein or which each graft and selective cannulation actually.
Okay. So we have one more question from Ahmed from
Blood
Morocco.
gives
I
this.
so
I have a question. Is
yeah.
just a
So actually, it's a so he's saying that he uses normothermic blood cardioplegia and it gives good results.
yes,
So as I said, normothermic blood cardioplegia, that is warm blood cardioplegia, it has a good result. As the most important benefit is that it doesn't cause reperfusion injury after releasing the clamp. So this is the most important benefit of warm blood cardioplegia or normothermic blood cardioplegia, because we maintain the myocardium activity, and after we release the clamp, when the when the coronaries are reperfused, the myocardium gets the oxygenated blood, and it doesn't have any reperfusion injury. Okay, so we'll wait for some time. If there is any question, we'll
okay,
discuss. We'll wait for 2 minutes. Yeah, so for especially for a ventricular dysfunction patient, I think warm blood cardioplegia is beneficial. So guys, you can comment your question. We are at the end of our session, so hurry up and comment your question. Okay, so thank you, Zahra, for joining us,
you're welcome.
and it was a wonderful session. And thank you for wonderful explanation. We'll
Thank
see you soon with the next topic,
you. Okay, sir.
and wish you all the best.
Thank
Yeah,
you.
it was nice having you.
Okay, thank you, and have a good time, sir.
Yes, thank you. Same to you. And thank you guys for joining. And we'll see you soon with another topic. And if you have any suggestions, you can directly DM or you can WhatsApp on the um, Global Perfusion WhatsApp number. And if you have any suggestions, if you want to discuss any special topic, you can directly DM us on Instagram also. So thank you guys for joining and wish you all the best. See you soon.